I welcome the next speaker, Dr. Monna Pandurangi. She is an associate professor in the Department of Reproductive Medicine and Surgery in Ramachandra Medical College, Chennai. She is member of the Tumor Board of Ramachandra Medical College, Chennai. She has a special interest in Doppler and fertility preservation, and she has many publications in national journal. Welcome, ma'am.
I thank Dr. Aruna, A4 Hospital, FOGCE for giving me this opportunity to share our experience on saline infusion sonography. Transvaginal sonography, though simple and non-invasive, has limitation in evaluation of uterine cavity because uterine cavity is a virtual space. You see, SIS, which involves installation of saline into uterine cavity during scanning, improves the accuracy of TVS. See, if we see, whenever we see this uterus, we say this is the uterine cavity, right? Can you see this? We think this is the uterine cavity. But what is uterine cavity? You see, when we instill the fluid into the uterine cavity, the cavity actually opens up. So this is the uterine cavity. This is the endometrium, and this is the functional layer of the endometrium. So what we are seeing the endometrium here, this is the basal layer. We need to understand the layers of the endometrium. This is the basal layer, this is the functional layer, and this central line is actually the cavity wherein the two walls are opposed to each other, and we are seeing it as a white area, white hyperechoic area, which is the central line, which opens up during the saline infusion sonography. So SIS, which is saline infusion sonography, takes the advantage of saline as a negative contrast agent and also utilizes the distension property of the uterus, thereby delineating the structural abnormality of the uterine cavity. So tips to improve interpretation. First and foremost is the position. Never do it on a table which is used for obstetric ultrasound. You will have to tell the patient to put up the buttocks up with 2 pillows, 3 pillows, her hand. That is not the way to do it. Use the usual gynec examination table, bring her to the edge of the table and use a transvaginal probe so that we can move the probe up and down and get the best picture of it. In fact, we do all our transvaginal scans on the cut table so that we don't have to tell the patient to put the hands below her buttocks, lift the buttocks. We don't have to do that. We can move our hands down as much as we want. Okay, so that's very important. So position is semi-upright lithotomy position with the feet in stirrups or even on the dorsal lithotomy position. Buttocks extended slightly beyond the examination table allows more freedom with the probe and speculum. IUI catheter is enough. Usually it gives good distension unless she is a multiparous patient where there is a leak, where we may have to use a HSG catheter or a small 8 French Foley's also can be used. 30 to 50 ml of saline is enough, but 20 ml syringe is usually used for that. To be performed in the early phase, otherwise the thick endometrium of the luteal phase may appear like polyp. Pre-procedure always don't start off, just painting and putting a catheter and then starting. First, before that we should do a baseline ultrasound. A pre-procedural baseline ultrasound imaging cannot be skipped. Look for the direction of the uterus. It helps us in putting the catheter properly. Look for fluid in the POD before the procedure and presence of hydrosalpinx, which if you have not seen, you may misinterpret it later when we are doing. Because if the fluid is already there, you cannot comment on the tubal patency. SIS procedure does not require anesthetic. A simple analgesic, what you are using for a HSG can be used, can be performed in an outpatient clinic. An analgesic antispasmodic can be given 30 to 60 minutes before the procedure. So some small tips, wherein we have to inject the fluid slowly. If you inject it very fast, it gives this movement, the movements, and it will appear hyperechoic. Okay, but if you inject it slowly, you can see the cavity open up. You see so beautifully the cavity can be seen, the endometrium, and you can even see the interstitial segment if it's taken in the transverse section. Okay, so what information you can obtain, what all you can see during an SIS, whether cannulation of cervix is okay, whether there is a resistance at the interlos, which is very important information if you are going to do an embryo transfer for the patient. The angulation of the body of the uterus can be obtained, the type of distension, endometrial abnormality in the sagittal and the transverse sweep, adnexal abnormality, fluid in the POD and uterine anomaly can be studied better along with transvaginal sonography and a saline infusion. Let's go through one by one. So what are the usual indications? Can be combined with a routine baseline scan, which is called one-stop assessment, and it can be used for assessment prior to the embryo transfer instead of a routine hysteroscopy, evaluation of a thick endometrium, evaluation of a uterine anomaly for tubal patency, and pre-operative evaluation of a submucosal fibroid. So let's look at them. So one-stop assessment was suggested by Geeta Narkund in 2001, and then it was reiterated again by Grossman in 2016. So what did they say? Between day 5 and day 9, after the bleeding stops, the first step is to do a 2D ultrasound of the pelvic organ, then do a 3D uterine anomaly. The third step is to use a saline infusion sonography and see whether uterus is distended or not. And the fourth step is you use a ultrasound contrast to see the tube, or you see for the appearance of the fluid with the saline itself, and you will know at least one tube is patent or not. Okay, so this is the advantage of doing a routine day 2 scan, or little later in the early follicular phase. If you do it on a day 2, you may see a thin endometrium like this, but if you do it around day 6, day 7 or day 9, you will see an endometrium which is looking triple line and reassuring. If you do it just pre-ovulatory, you will see a triple line and with a vascularity. And if we do it, if there is a polyp, it can be seen so well. And if you have done a saline sono, you know it is definitely a polyp. The same thing if you are done on day 2, you will see a structure like this, which can be a clot or a polyp, which requires a re-evaluation during the follicular phase. The same way you can do a scan for ovary, you can see all these follicles in the early follicular phase, late follicular phase, you will see a dominant follicle and a well vascularized follicle. So the message is, you can do a scan anytime the patient comes in, it can give you an information, and if you have doubt, you can call her back on day 2 with some reports and re-evaluate her. Okay, so we did a one-stop assessment, and what were our observations? We found that more than 50% of the patient had endometrial thickness of 7 mm, and almost 50% had triple line endometrium. We had seen a dominant follicle telling us they are all ovulatory patients, and we did an SIS, and 91.3 had fluid in the endometrium, suggesting at least one tube is patent. 3 patients hydrosalpinx which were not visible were seen only on SIS, and 1.3 patient had an adhesion. So these are the adhesions here which were picked up on saline infusion sonography. One is intrauterine adhesion, and this is the adhesion in the pelvic cavity which was seen only because the fluid appeared in the cavity. And this is also an adhesion which was seen after saline infusion sonography. Now second, when evaluating the uterine cavity before embryo transfer, SIS is a good option. Uterine cavity abnormality may be seen in 16% of the patient. It's a gold standard to evaluate. Why SIS over hysteroscopy? USG enables visualization of the myometrium also, adnexa, and evaluates the cervix and the uterine length, which is not possible by hysteroscopy. 3D SIS allows visualization of the whole uterus and is useful in diagnosis of congenital uterine anomaly. Cannulation during SIS helps to note the direction of the uterine cavity and to discover any unanticipated difficulty in entering the uterine cavity. If you take a hysteroscope, you will go up, down, negotiate it and finish off evaluating the uterine cavity, and you will really not be able to document in your notes how to enter in with your catheter. That's where SIS scores over hysteroscopy. Okay, so you can measure the uterocervical angle, the uterocervical length, and note this angle. There was a study done long back by transabdominal ultrasound to see what angle which is greater than that which prevents implantation, but this is a transabdominal, where they said if it is more than 60 degree, that means it's an acutely antiflexed uterus where you may have difficulty. The same thing you can measure on a transvaginal scan while doing an SIS and get a similar information. And this is what they said. Fertility Study 2022 said modern assessment of uterine cavity can be done with with an ultrasound. SIS has demonstrated diagnostic accuracy approaching that of hysteroscopy and enabling visualization of the external uterine contour and myometrium. Therefore, we recommend SIS rather than the diagnostic hysteroscopy as the first line assessment before embryo transfer. And diagnostic hysteroscopy use should be limited. Now evaluating endometrial cavity. Now if you have a thick endometrium, is it hyperplasia or a polyp? How do you differentiate? Many a times you have seen when you go do a blind DNC for a thick endometrium, you will see reports saying no tissue obtained. Okay, why did you not obtain a tissue? maybe these are the patients who actually had a polyp and not just a uniformly thick endometrium, and that is why you missed the tissue during your blind DNC, and if you had done a histoscopy probably you had pick up. So if you are not doing a routine histoscopy for thick endometrium, take a biopsy, definitely SIS should be done to rule out whether it's a thick endometrium, uniformly thick, or a polyp, and if it is a thick you can do a blind DNC and take a tissue for histopathology, whereas if it is a polyp better to go for histoscopy. That's how it's going to help us. So this is important picture I would want to show. This is a triple line endometrium with an echogenic foci in the functional layer of the endometrium. This is the functional layer, and if you see this picture and you say wow, it's such a small polyp sitting there, and you will go on seeing it during every picture of when you are preparing the endometrium, you think it is better to be removed. But if you do a saline infusion sonography or you do a histoscopy, you will not see them, because these are within the functional layer of endometrium, not projecting into the cavity, and you will miss it. So they don't have to be removed. So that's how the saline sono infusion evaluation will help us. So polyps are structures which are present within the uterine cavity and not within the functional layer of the endometrium. That's very important to know. Okay, here we thought that these are within the functional layer of the endometrium in this sagittal section, but when we did a SIS, in few other areas we seen them projecting into the cavity, and that's when you see a 3D, beautiful 3D can be obtained, and that's when we resorted to hysteroscopy. Uterine anomaly, we say call the patient back in the luteal phase so that you have a thick endometrium like this, and you can evaluate the uterine cavity and get an information what type of uterine abnormality it is. But why not? Why not in the follicular phase? Combine it with SIS. If you inject, you see the beautiful cavity. This is normal, this is arcuate, subseptate, and you can differentiate it so well. This is where SIS plays in identifying the uterine anomalies. And examination of the tube by a 2D ultrasound can be seen only if they are dilated. You may have these different pictures, incomplete septas, your fusiform cystic structure, pearl on ring appearance, okay, here. But if you have some fluid in the peritoneal cavity, you can see a tube floating like this. But then how do you know whether it is patent or not? Okay, this is a rare picture which can be obtained. When you do an SIS, you can see this tube floating and you can see the fluid coming out. But this is not routinely seen. This we very rarely, only one patient we saw like this, beautifully coming. So usually what we do is, when we do an SIS and we see fluid in the POD, we know that at least one tube is patent. Or you do a Doppler in the adnexa when you are pushing, and you will see this flush sign and you know that the tube is patent. Sometimes it is difficult to get, particularly if there are large vessels close to that. Okay. You can, yes, for tubal patency, you can use ultrasound based contrast, which can be air with saline. You can push in and you can see the sort of filling here, hypophy, or there are other contrast medias like EcoVis, Sonoview and Exofume, but they are costly. You can do a 3D along with that and get beautiful pictures like this to say whether the tubes are patent and there is filling or not. Now this is a scan wherein you are seeing a submucous fibroid. But how much is projecting within the endometrial cavity, we are not sure. So fibroid appear as hypoechoic areas, okay, loss of endometrial myometrial junction and a branching vascular pattern. But if you fill in this cavity with some fluid here, you can exactly say how much is projecting in. You can do your FIGO classification and then decide as per, you can decide as per step W classification to find out whether this histoscopy is going to be difficult or it is easy, and it has been shown by this study that using SIS along with 3D can help in scoring this system better than doing TVS alone. It's almost done. This is virtual histoscopy wherein you can combine 3D and almost go through the cavity, seeing the polyps within it, and then decide whether you can go in for histoscopy or not. Okay. To conclude, sonography is an accurate, non-invasive, cost-effective imaging modality for examining the infertile woman, combining TVS pelvic imaging and using saline contrast for visualizing endometrial cavity and adnexa. Accuracy of interpreting pelvic ultrasound in clinical practice can be increased, almost replacing the use of endoscopy for diagnosis. Thank you.
Thank you, madam.